Welcome to participants in Zoom and YouTube livestream viewers. This webinar, Going Dutch on Global Health, How the EU and the Netherlands Could Do More, is organized by the Klingendaal Institute with support of Coordate, KNCV TBC and the AIDS Fonds. My name is Louise van Schijk. I'm head of unit at the Klingendaal Institute, and the Dutch and EU role in global health is one of my fields of expertise. I will be the moderator of this webinar. With the COVID pandemic, the world has learned again the risks of diseases respecting no borders. Preventing and halting outbreaks of new diseases is a tremendous challenge that requires concerted action by countries that are also willing to share information. Instead, we witnessed intensified geopolitical tensions combined with national reflexes and closed borders undermining a global response. Eventually, during the pandemic, the EU and its member states, as traditional defenders of multilateralism, got their act together and initiated the global arrangement for vaccine sharing, COVAX, that's effectiveness is now much debated, and are currently also advocating for a new pandemic treaty. They managed to uphold the World Health Organization when it was criticized by the US and others. This event will discuss if the EU is likely to continue its efforts to push for global health, and in doing so, if it can do it in a more coherent way than previously, when the activities of health and development tracks were not much aligned. What could be the contribution of EU member states in this respect, including the Netherlands, that traditionally focuses its global health efforts on sexual and reproductive health and rights? What is the added value of looking at health as an international issue? What are rather nationally oriented health ministries missing in the bigger picture? And how can development actors pay more attention to public health security interests? We will look at these questions with an excellent set of speakers, each speaking in personal capacity and joining from their own backgrounds on this topic. Please give them a virtual round of applause. First is Professor Maria Jasdambaksh. She's the head of Department of Parasitology at the Leiden University Medical Center, and she's also the winner of the 2021 Spinoza Prize, which is so-called Dutch Nobel Prize. And it's also a big acknowledgement for her outstanding research achievements. With her, we will discuss the role of scientific research in addressing global health challenges. Then we will move on with a panel with three distinguished speakers. The first is Koos Lichel, member of the International Advisory Council on International Affairs that's currently preparing an advice on global health, and also former Director General at the European Commission and at the Netherlands Ministry of Foreign Affairs. So a long-standing track record in the field of development. Roland Driessen, the director of the International Department of the Netherlands Ministry of Health, and also a key role in the vaccines purchases by the EU. And Eleanor Brooks, a lecturer in health policy at the Global Health Policy Unit of the University of Edinburgh, who has published a lot about the European Health Union and the recent developments during the COVID pandemic. We have prepared a conversation on different aspects of the role of the Netherlands and the EU play in the field of global health. It is my pleasure to ask the participants to join in the Zoom to join the conversation and ask questions to the panelists through the Q&A function in Zoom. And some of you have already also posed questions during your registration. My colleague, Martijn Haas, will help me with selecting the questions and make sure that as many as possible are posed to the speakers. Okay. Now I would like to ask Professor Maria Jasdambaksh to take the floor. Professor Jasdambaksh, we are so pleased to have you in this webinar as Spinoza Prize winner for your outstanding academic contribution. Through your work on parasitic infections such as malaria, you make great contributions to the global fight against poverty-related and neglected diseases. How do you view the role of the Netherlands and the EU in supporting top-notch research in the field of global health? Please.
Thank you. Thanks for involving a basic scientist into this conversation. I do believe that global health has different layers. We all know that. It starts from fundamental research. It should be also, included in the conversations to implementation research. And I think what is important for the European Union, but also in particular for the Netherlands, is to kind of try and stop this trend of inward looking. We're very much directed towards Europe, towards the Netherlands, and global health has to be, of course, in collaboration with many countries, international, but then not just with the American Harvards or big European institutions, but we have lots of talent in so-called global South. There are many people who want to work together, and that characterizes, I think, my work, which has been supported by the Netherlands and the European Union, and that can be to a much more extensive level, and also in a systemic way where we also collaborate with different stakeholders, not just the fundamental scientists. So I would like to just give an example. The vaccines. Vaccines are the cornerstone of public health. We all agree, especially in this time. And by doing very fundamental work with scientists, top scientists from Africa, top scientists from Southeast Asia, Indonesia in particular, we have seen that vaccines which are produced based on what the immune system, so immune system is very important when we want to develop a vaccine. By studying, vaccines are produced based on the information we have from European American immune system. By working closely with Global South, together we've discovered that the immune system is very different when you go to Africa, when you go to Southeast Asia, particularly in rural areas. And it's not just genetic, but it's the environmental factors. So malaria vaccine that works 100% in Europe, you go to Africa, where it's most needed, it works only to 30% protection. I mean, this really shows, and by looking at fundamental differences in molecules, we can change the vaccines in a way that can also be effective 100%. My research was not possible. Spinoza was not possible if I didn't have this close, really honestly equal partnership with excellent researchers in Africa or in Southeast Asia. So, I always say, we started together, we defined the problem together, everybody brings to the table what do they want out of this partnership, and we move forward. And these are the things that we can contribute. And I think really at all levels, this equal partnership, if Europe, the Netherlands could really say, we're going to be leaders in this kind of partnership would be great. I really believe in it. Yeah, we need to have these vaccines, for example, and then, of course, the distribution and sharing. But if you know the people you're working together on vaccines, it will trickle down where you also will eventually maybe have good faith in each other, how you're going to distribute the vaccines. That's what I would like to say. I think, a lot more can be done, but a different way of working together, maybe.
So this, I guess, links also up to other, let's say, Klingendahl research on EU-Africa relations and, let's say, a renewed understanding of how this relationship could look like, perhaps. In the research that we are currently doing on the role of the EU and the Netherlands in global health, we came across the case of the European and developing countries clinical trials partnership, and their director has also participated in one of the previous health webinars that Klingendahl has organized. And the Netherlands is actually a host of this organization, based here in The Hague, but it's perhaps one of the least known international organizations here in the country. The European and developing countries clinical trials partnership is a partnership between countries, or rather the institutes located on their soils in Europe and sub-Saharan Africa, and it's supported by the European Union, and it's engaging in these clinical trials. So it aims to accelerate the clinical development of medicinal products for poverty-related infectious diseases. And thereby, it's really one of these examples of a global health effort for poverty-related infectious diseases, and also an example of an effort at the cross-section of health research and development. It is also perhaps worth mentioning that its clinical trials capacity was put to good use during the testing phase of the new COVID vaccines, because it was there, it was available, so it could be used. Could you perhaps explain in your words to our viewers what this organization means for addressing global health challenges, and how researchers based at Dutch universities already contribute or could contribute more to its work in the future?
Yeah, I think EDCTP, so this platform you're talking about, I honestly, and it's not just me, but many scientists and practitioners at all levels believe that's an extremely successful program. It's been an amazing program run by the European Union. I'm surprised that it's not better known. Maybe we haven't done a better job of advertising it, to be honest, to the governments, to everyone. But it's such a successful program that has really built partnership, and good partnership. Of course, there's always space to improve, but this partnership has been great for testing, indeed, not only drugs and vaccines, developing them and testing them in clinical trials, in sub-Saharan Africa. These partnerships have meant, as you said, that the vaccine, the COVID vaccine implementation was very quickly, through help from EDCTP, really could take shape. But please don't forget also that we know that COVID is taking an extremely different turn in Africa, and EDCTP was extremely quick to implement, a quick call. People, because they knew each other, formed very quickly partnerships to study these differences. What are the problems there? What are the differences from Europe? How can we tackle? What can we learn from each other? What can we learn? Africa was great in, they're used to pandemics. They could teach us how to deal with pandemics, why are we waiting? We can go to our experts there and learn from them. And these are things that EDCTP can really facilitate. And to hear that the Netherlands might be thinking of not contributing is just beyond belief. Such a successful program. The moment you stop that, you're going to lose 10 years of excellent funding of very good networks that can quickly tackle global health problems.
So yeah, I feel that we have to explain this. So this initiative is supported with EU funding and also member states funding, and it's now entering a third phase. And it's not yet clear if all the member states will contribute, including the Netherlands, whereas this organization is hosted here. And that's that has to do also with the choices that are made within the health field of the Netherlands and the mandates.
Sexual health, that's also supported by Germany, France. It's not as though the Netherlands is the only country that is supporting that program. And also you're doing that in a different way. You're supporting, it's very important to support that, but that doesn't mean that you don't continue contributing to EDCTP. That's a different type of research. That's a different type of dealing with global health issues, much broader. I think it's really important that we continue, as the Netherlands for sure contributes to this program. And many Dutch researchers are also benefiting from it, as many researchers in sub-Saharan Africa are benefiting from it. These networks, once you stop, as I said, is destroyed. You can't build it so quickly up. That's another 10 years to build such networks up.
Mm-hmm. All right. Yeah, thanks. So yeah, that's one of the examples that we came across where we noticed that, let's say, the comprehensive view on global health is maybe more needed to see the value of such initiatives now and also for future global health challenges. Thank you so much, Professor Jasdewanske, and we greatly appreciated your presence and contribution to the webinar. And we hope you will stay on. People might ask questions, have questions for you.
Okay, thank you.
Yeah, we hope to see you a bit later. We now start with the panel. Thank you. The panel that will focus more at the policy contributions of the Netherlands and the EU to global health. I would like to ask if the panelists can be made visible: Koos Richel, Roland Driessen, and Eleanor Brooks. Let's see. Yeah, I can see Koos. Koos, Richel, you have been a senior official in both the Netherlands Ministry of Foreign Affairs and the European Commission, serving amongst others as the Director General for Development Cooperation, which is currently called DG INTPA, International Partnerships. And now you are a member of the International Advisory Council on International Affairs that is working on an advice on global health. But we agreed that today you speak in personal capacity, since the advice from the IFA is still in the making. So you cannot represent it yet. What are your main observations with regards to how, let's say, the Netherlands and the EU responded to the COVID pandemic and in the field of global health? How do you witness the role of the EU and the Netherlands in the recent, let's say, 2 years, 1.5 years, please?
Well, thank you for the introduction and underlining that I speak in my personal capacity. That gives me the freedom to use my own language, so to say. And it could perhaps be more interesting. It's very difficult to compare the two approaches. If I would do, I think they converge in one thing. What was done was too little, too late. Let me start with the too late. Based on previous occasions, there has been work done on an early warning system. But such systems only work when the data entry is okay and when people listen to the alarm bells that are ringing the other end. Now, on the receiving end, the data entry, things were oppressed. And it was not done in a very transparent and open way. But the alarm bells were also not heard. The first signals were denied and downplayed, really. And perhaps that was based on a subconscious extrapolation of the experience with previous outbursts of contagious diseases. For instance, Ebola, which was contained in some countries in Africa, and SARS and H5N1, the avian flu, that was contained in Asia. But this time, it didn't work that way. And when the effects came clear, we wasted a number of months. And the result was panic. Panic because of the size of the pandemic and the intensity, but also because there's really no blueprint or action plan linked to these kinds of events. Everybody seeks resort in its own corner, and then you get a very egocentric nationalist reaction, and that is not very conducive to finding a solution for a pandemic. Now, this nationalist approach was one of the elements that caused the delay in the actions of the EU. But of course, there's linked to the EU also an institutional problem. Public health is an area of shared competence, meaning that all the member states and the Commission have to work together. And usually the pace and intensity of that cooperation is being determined by the member states. And they are always reluctant to give up part of their autonomy, of their freedom. So that also made it very difficult for the EU to act. And then when the EU acted, it was first and foremost concentrated on EU business. The development and availability of vaccines for its own population, and the management of border issues, internal border issues, where every country went its own way. So it took them a long time to realize that we were in a pandemic, and in fact there were global effects. And then the reaction was too little, I must say. Again, only focused on vaccines, and not even in sufficient large quantities and in very big speed. The Advisory Council on International Affairs published an advice in May 2020 saying, come on guys, you need to do something. You spend billions in your own country, make at least 1 billion available now for acute misery in developing countries, and make sure that for the coming years you keep your budget up and don't lower it. Well, what we got in the Netherlands anyway is a bit of a marginal approach here. By far, there was not made 1 billion extra money available. It came down to a few 100 million extra, and the rest was an advancement of parts from the budgets in the year 2022-2025. So it's a bit of a scrapey reaction to this whole thing, and the EU talks about bigger money, but is also very much focused at the moment on the vaccine issues. I think we will come back to that later. So that's my explanation for the conclusion: too little, too late.
Okay, loud and clear. Thanks, Koos. I would like to go over to Roland Driessen, the Director for International Affairs at the Netherlands Ministry of Health, and highly involved in the vaccine deals that the EU made on behalf of its member states. Roland, could you elaborate on how the pandemic has impacted on the priorities and the work of your department in the ministry? Please.
Yes, well, thank you very much. And thank you very much for this invite, of course. And this pandemic influenced us all, and the Ministry of Health absolutely in huge quantities. Not only my own department for international affairs, but the whole ministry actually was turned upside down, as you can imagine. We went from being a policy or driven organization to a crisis response organization with a lot of new roles we had never done before. And I leave it up to everybody to make their own judgment on it. But for example, the procurement of vaccines, the procurement of mouth masks, the procurement of tests, we had to develop a whole new organization to deal with that. And a lot of our capacity of the whole ministry has been put into that. And personally speaking, I think we did a hell of a job. Not always as good as some people would have seen, but I think under the circumstances, it was a remarkable achievement we have done and still are doing with so many people who are working their butts off actually to get it all done. So I'm really happy to have seen that. And of course, there's a lot of things you can say that could have been done better, but if people would see how not just the Ministry of Health in the Netherlands and not just the government in the Netherlands, but many countries, I think, who are going through the same situation are dealing with this and working very hard to deal with this. I hope that everybody would have some respect for that, and at least I have for my colleagues and for my fellow workers in that respect. But apart from that, a lot of other things change as well. The perception, for example, of the role and the importance of public health. If you look at the ministry in the Netherlands, for a long time, it was cure, long-term cure and long-term care, healthcare, those were the things that mattered the most within our ministry. And of course, we always had a directorate and a directorate general for public health, but previously we were always the little brother next to the big ones. And in this pandemic we have had, you see a very much revaluation of the role of public health, and the director general for public health has become at least just as important as the ones for curative care and long-term care. And I think that's a very healthy development, unless we needed a pandemic with all the problems and all the grief that it caused to make that happen. But I think that the reoccurrence of public health as a major driver for health policy is very very positive in that sense. And I hope that we can keep that momentum up. And if I see the discussions for the next cabinet, we also see that prevention and public health are very much in the heart of that. So I'm really hopeful that we will maintain that. But what also was different was, let's call it Chefsache auf Deutsch, that you see that even at the level of a prime minister, that health and public health and the health response were at the heart of his agenda, and I'm not sure if that's going to be like that for the next couple of years. But again, at the highest political level, the occurrence of public health issues on that agenda is something very important and also positive, I would say.
Okay, thank you. So that's very clear on that health has really changed, and the pandemic has really changed, let's say, the work of the ministry. I would like to go to Eleanor Brooks. You're a lecturer, you're based at the Global Health Policy Unit at the University of Edinburgh and specialized in EU health policies. Eleanor, what are your reflections on the EU's contributions to the pandemic response? What are your main, takeaways from this period?
Sure. Thank you, Louise, and thanks for the invitation to join the panel today. I don't disagree at all with Mr. Rochel's characterization of the delay, but I think it's useful for us to think about the EU's response, sort of separating the short term and maybe the medium to longer term response that we've seen. So the short term response by the EU is concerned with two things, I think, and that was direct assistance, how the EU could directly assist in mitigating the pandemic, but also in the EU getting out of the way of the national response. So in terms of direct assistance, we saw the ECDC, the Centre for Disease Prevention and Control, gathering information, producing guidance, distributing information. We saw the Health Security Committee providing a platform for senior health ministry officials to coordinate action and to exchange information. Also the civil protection mechanism, we saw that used to repatriate citizens, for instance, and deploy some medical teams where those were available. But that direct assistance was quite limited, in the ways that have been described. The EU's public health mandate is tightly constrained, so that there is not a huge amount of resource or mandate there. The second part of that short-term response, I think, is quite telling, because that was about the EU getting out of the way, recognizing that the major decisions and the major resources were coming from the national level, at least in the very first months of the pandemic, and that actually what was important there was that EU rules were not obstructing national governments from doing what they needed to do. So, for example, one of the first decisions that the EU took was to suspend its fiscal governance framework, right? So the rules that say that member states cannot accrue large amounts of deficit or debt. That's important because it recognizes that what national governments needed to do was spend a lot and spend it quickly. They also suspended or amended rules on state aid so that countries could support their own national companies and institutions and organizations. There were also delays to the entry into force of key pieces of legislation. So medical devices would be a good example there. The entry into force of that new set of regulations was delayed so that companies could focus on producing the medical devices that we needed there and then. So a lot of that short-term response, that there was a small amount of direct assistance because that was all that was available, but a lot of that was about making sure that the rules and the procedures that we have predominantly to ensure the functioning functioning of the internal market weren't getting in the way of a national level response. And what I think is interesting about that is actually the more substantive EU contribution, I would argue, is coming in the longer term. It's coming with a new health programme that has a budget 10 times the size of the previous health programme. It's coming with these proposals for a European Health Union that I'm sure we'll talk about as the webinar progresses. Also the recovery programme, the long-term recovery programme, that's an unprecedented amount of money to support, among many other things, pandemic preparedness and wider health system strengthening. So I think my main reflection on how the EU contributed, it contributed in the short term as we could expect it to, given the mandate and the roles that it has. In the longer term, it's contributed in a way that nobody would have anticipated at the end of December 2019. That was not what we've seen since then was not something that would have been predicted by anybody working in EU health policy, I think, and has the potential to be much more significant.
Mm-hmm. Right, thanks, Eleanor. And thanks also for pointing out all these issues that the EU has to do also internally, you know, among the EU member states. Now, actually, we wanted to look a bit outside. So also back to Co-Seychelles. Diseases know no borders, but the field of global health is actually broader than only combating infectious diseases such as COVID. At the same time, we've witnessed that health is a topic that's very much, of course, a national concern. It's a big expenditure on the budget of any national government, both in a country like the Netherlands, but also for developing countries. How do you compare the way the Netherlands and the EU are contributing to supporting developing countries to address global health?
First of all, global health is a relatively new concept, at least when you link the concept to the idea that we should consider health not only be the responsibility of one sector, the public health sector, or the health sector in general, but that we speak about one health. And in that one health, you have a shared responsibility with other sectors. Now, in that sense, we have to learn ourselves a lot, even in our countries, on what that would mean and how you could combine, let alone that we could lecture developing countries in how one health should look like and what they should do. So there's a difficulty in getting that across, I would say. Then there is no real definition of global health. Let's take SDG 3 as the definition of global health, the target to strive for. And if you then want to have a strategy, then you need to explicit norms and values and ways of means of going into the direction of those targets. Now, you see that there's no world paper on this issue. And what we see is a lot of national global health strategies. And at least they call themselves global health strategies. What we should not do is add another paper, I think, to those strategies, the Dutch global health strategy, and certainly not if we interpret it as defining the content of such a strategy. You could define, of course, if you call it under that name, you could define some action programs for discussion with others. But one of the best contributions would be to work together with the multilateral and international organizations to get a common and shared vision on where we should go in this direction. In terms of health, we are not different, I think, from any other area of development cooperation. Development cooperation is characterized for a long time by a high focus on input and not so much on the output. No real attention for best practices and a turnover of policy areas like fashions.
Koos, could you say a few more words on what you mean that it has been defined by input and not so much by output for the people who view this webinar?
Oh yes, do good. and brag about it. Plant your flag somewhere and show that you spend some money. The attention for output and results has only come about with the Millennium Development Goals and the Sustainable Development Goals. So it's something of, let's say, the last 10, 20 years, and it's very difficult to put it in practice. So you see a high turnover of priorities and fashions, you could also say. And in that sense, everybody is free, every new minister is free, every new commissioner is free to set a few markers in this area. So some put it on public health, some put it on sexual and reproductive health. We recently have in the Netherlands also seen an attention for mental health, specifically in post-trauma situations. That's all fine, that's all very correct, there's no problem. But for global health and the realization thereof, I think you need institutions. And you need systems. And building institutions and systems is one of the most difficult things to realize. It starts basically outside the sector of health, for instance, with governance. If there's no governance, you cannot make policies, you cannot make and implement laws, and so on. So it's in that sense that we first should have a big idea on what global health is, what the main markers are, how we can support other countries, and we are not in a position to lecture them or to present them the best practice or model. I hope I contributed enough to the confusion to provoke a debate.
Okay, thank you. And also to go back to how that could be done for the field of health, the health systems focus, for instance, health system strengthening focus that is very much talked about a lot. Let's move on to Roland Driessen again. Roland, the Netherlands has been a strong supporter of the global health security agenda with the focus on One Health. So usually that's also understood as kind of the spread of diseases from animals to humans, as we most likely have witnessed with COVID, although we're not 100% sure. And another priority area for the Netherlands has been antimicrobial resistance, AMR, which occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to the medicines that are meant to fight them. So, for instance, antibiotics don't work anymore. Parts of the global health security agenda was also to bolster the implementation of these international health regulations that fall under the auspices of the World Health Organizations and were, and still are, I guess, the main instruments for preventing and addressing the outbreaks of infectious diseases. So they set kind of the rules of what countries should do when they find out about new diseases, how they should report to whom, and so on and so forth. But now the EU has proposed to negotiate a new pandemic treaty and also to kind of step up the level of international cooperation on, let's say, fighting and preventing, addressing pandemics or potential pandemics. And the EU has also suggested to improve elements of the international health regulations which were not functioning so well during this pandemic. From the perspective of safeguarding health of the Dutch citizens, what would you consider the most helpful in terms of international cooperation in the field of global health, and also specifically with a view to better handle these infectious diseases in the future? So the instruments that we have, are they sufficient? How do they need to be changed? Is there a chance for this pandemic treaty to become a reality? Could you say a few more words about that?
Yes, I would. And you want me to answer all these questions in 2 or 3 minutes, which is, of course, not possible at all. Maybe I need 2 or 3 hours to address all these issues, because they are very interesting, important, but also not easy to explain and to organize the solutions of them. Yes, it is true that we were propagators of the global health security agenda before this pandemic broke out. And yes, of course, in the Netherlands also, we have implemented the IHR in our public health law. And but to be honest, nobody, including ourselves, would have thought that we would ever come to think about these things as a problem for ourselves. We always thought a pandemic of this happens somewhere in the world, but not something on a global scale, and at least not in Europe or in the Netherlands or whatever. Not at the scale we have witnessed and practiced. And like I said in my previous contribution, this makes that we look at global health, public health, and international health differently than we did 2 years ago. And then we also said those kind of things, but now we have witnessed that they mean more than just words, and that we need to do something. And if you look at our pandemic preparedness program, which we are preparing at the moment in the Netherlands, but you see it all in different countries as well. The global dimension of that and the European dimension that as a part of it is very much involved in that. Yes, we go on with the global health security agenda, but interestingly enough, about each global health security agenda, I think the work we are doing there is very useful, very important, and very good. But then you talk about global health, and what is global health? That is the whole coming together of all interests in the world which determine health for people. And if you put the political perspective into it, then you already witness why this is so difficult. You already mentioned this is probably a zoonotic, and this pandemic had probably a zoonotic cause, but formally we do not know that. And why don't we know that? Because it is so difficult to speak about it as countries in the world, because we do not fully trust each other, because the political dimension lying underneath all the problems. At the same time, we only have one world. We only have one set of countries dealing with each other in this world. So we need to find solutions. And then we get to this pandemic treaty. I think we're all struggling a little bit still with what this treaty should be about. Yes, making sure that this will never happen again. Well, maybe that's over ambitious, but that's at least just the starting point. How do we make sure that this kind of problems on this scale will not occur again? And then, yes, we should make sure that all those rules we have written down in the international health regulations, which are in itself actually very good. Everything is there on paper, but putting them into practice is not so easy for political reasons, because some countries do not like it, for example, if other countries look with them what's going on in their countries, because it has a relation with their defense infrastructure, for example. So there are many reasons why this is politically complicated. If you look at, for example, what this global health security agenda is really about, is helping countries. So countries helping other countries implementing those IHR regulations, putting money into it, putting expertise into it. And I think we should keep on doing that, but also with an open eye to ourselves, because helping Uganda or Senegal or Vietnam or whatever country you could name, but look inward as well. How well have I done in implementing those rules? And are we fully compliant with those rules? So that should also be part of the solution, not thinking that is just something for other countries. But there's so many things we could do which could fall under such a treaty. It's been mentioned that the procurement of vaccines is supposedly not equally disturbed around the world, so it's not fair. Maybe the way we dispatch those vaccines. How can we make sure that the availability of medical products is there for everybody? Is that possible? And how do you organize that? And what price does that have in terms of money? And where do you find that money? Then we talk about setting up funds for public health. There is so much you can do and have to do the next couple of years. But it takes political will, it takes money, focus. And the question is, of course, how long do we maintain this focus and this urgency when we get over this pandemic? And I don't have the answer to that yet, but that's going to be the interesting question, I think, for the coming years.
Mm-hmm. Yes, I fully agree. And I think this is also a very good bridge to a question I wanted to pose to Eleanor. So I know that the EU is very keen to negotiate or to get agreement on such a pandemic treaty, but it's also very difficult in the current international environment. So what if the EU does not manage to pull off a new pandemic treaty? Does it have other means to support a strengthening of pandemic preparedness? And also, will these new institutions and maybe science cooperation, but also the new institutions like the HERA, be able to help out in this respect? So what can we expect from the, let's say, the international, implicit international dimension of the European Health Union ideas, please, Leonor?
Yes, I think the key word there you said right at the end is implicit. There is not, to my reading at least, particularly well operationalized international global health aspect of the European. I mean, indeed, the entire European Health Union remains somewhat underdefined at the moment anyway. So I think there are sort of two answers to your question. Do we have an alternative set of structures to assist with pandemic preparedness within the EU in the absence of the treaty? Yes, we do. We have many things either already in place or in the pipeline. That's quite clear. The treaty was the global element in my reading of the EU sort of set of initiatives that are being adopted right now. So that was the part that would translate into a bit more of a global health face. Internally, most of what we've seen developed or created or proposed over the last year to 18 months has focused on pandemic preparedness. So it might have wider health objectives rolled in as well. We have a health agenda, but the core pillars of it are about pandemic preparedness and crisis response. So that will mean the EU supporting, as Roland was describing, the Dutch development of a national preparedness plan, right? There will be an EU mechanism to support all member states to develop their national preparedness plans. There will be exchange of technical guidance and information and these things. There will be a stronger mandate for the ECDC to address the data issues that Koos was describing earlier when feeding into the early warning system, these problems where countries are not inputting the same information, the same data, or measuring things in the same way, or defining cases in the same way. All of these weaknesses that we've identified in the response now are being addressed, or plans put in place to address them within the EU for Health programme, within the package of measures that was released in November 2020, within the Health Union, whatever we choose to include underneath that umbrella, and also within the HERA, as you mentioned, so the Health Emergency Pandemic Response Authority, which is going to be an internal commission body that will try to focus very clearly on pandemic preparedness and response. The HERA has a global element. There is within it a section in the proposal that talks about the global dimension and how it will work with international partners, and that's particularly around issues like bottlenecks in supply chains, so focusing very much on the problems that we've seen in the supply chains for components for pharmaceuticals, vaccines, but also more widely pharmaceuticals and medical devices. So it takes quite a sort of vaccine medical technology focus, but it at least has an international dimension there. I think the concern from a global health perspective is that the tools that I'm describing are primarily internally focused, and the international treaty is the part that would bring a global health focus for the EU. Somebody's mentioned in the Q&A already the current global health policy of the EU, insofar as we have one, is already 10 years old. So the treaty would at least give some shape to, and presumably be supported by, an underpinning sense of what the EU's global health policy might be, in a way that we haven't now seen since that one set of council conclusions in 2010.
Right. Yeah. Thanks. Yeah. Together with Klingenau Associate Fellow Remke van der Pas, we have written quite a lot about the 2010 council conclusions at that time, and how quickly they kind of faded away and were not really, they were not really owned by the member states, if you could say. And yeah, would be really important that the current efforts do not replicate this, but try really to unite more the development and research and health circles around a unified approach. And this pandemic treaty could be a way to bring together these worlds, but maybe, as I indicated, there's more also on the agenda. Actually, you also pointed to people already posing questions. I see the numbers go up, and I would really like to go to Martijn to ask. Martijn, maybe you can pose maybe 3 questions and see, please also indicate maybe to whom they are addressed, if we know it, and then we'll see if we can do a round of Q&A. Please, Martijn.
All right, we have a first question by Corinne Hinlopen, which I think would be perfect for Eleanor Brooks, which picks up on what we just discussed on pandemic treaty. So we already have the international health regulations under the WHO and the global health security agenda. Now, what would be the added benefit of a pandemic treaty if we could already implement the IHR, so the international health regulations, and this global health security agenda, considering the political capital and time it costs to negotiate a new treaty? Then there's a question for Koos Richel, exactly on the EU's global health strategy. Would you say that the EU needs a new global health strategy, or what would be the added benefit of that? And maybe an interesting question for Roland Driessen would be how the international cooperation has changed within your ministry. So what new lines of cooperation have you established with other organizations, and how has your relationship with the Ministry of Foreign Affairs evolved over the pandemic?
Right, and perhaps Roland, if you wish to say a few words about the pandemic treaty, that's of course welcome too. But let's first move to Eleanor. Eleanor, please.
Yeah, certainly. I should preface immediately that I do not study global health. I study European health, so this is not necessarily directly my field. But I would, with that caveat, maybe put forward a couple of ideas. I think the first is that part of it might be to do with harnessing political enthusiasm. Enthusiasm for implementing something that has not been well implemented is always going to be slightly lower than something new and shiny and representing a coherent global response to something very pressing. I suspect the second part is a bit more pragmatic and has to do with learning lessons, in a way that would be difficult or awkward to integrate into some sort of increased implementation of the IHRs. There must be a reason, and indeed there's a lot of research on the reasons that the IHRs are not well implemented. So my suspicion is that the role of the treaty, if you like, is going to be to better encompass the lessons that we've learned from COVID-19, rather than focusing on something that we already know is very difficult to do. I wonder if a third point might be to do with the EU waving a flag about its role in global health in a way that it hasn't done in a long time, as Louise was mentioning. That could well play a part into it, but as I say, this is not my primary area of research, so it may be that other people are able to shed a little more light on that question.
Yeah, perhaps Roland, you would like to add to that. So why all of a sudden is the EU coming up with a pandemic treaty, and why not simply reform or upgrade the international health regulations and support their implementation? You talked already a little bit about it, but maybe what explains the political?
It's not just the EU. Let's start with that. It's not just the EU. It's also the Director General of the WHO himself who pleads for a treaty, and there are more countries to do so. If I would translate it in my own words, I think there are a lot of ideas and proposals and initiatives to make sure that we don't end up in the same situation as we have been or are still in. And if you all put it all together and draw a box around it, maybe that is your treaty. I think today or yesterday, the Director General of the WHO, we spoke in Berlin on the world's global health. I'm not even sure what the formal title of that festival was, but he said no more little initiatives, but let's just focus. Let's just come up with a agenda on this, and maybe such a collective agenda is the treaty we need. If you talk about bringing together money, access to medical equipment, making sure that countries can actually implement the IHR in a proper way, maybe all those things together and the facilities you put in place to make that happen, that could already be a treaty. But I think that the biggest challenge we have as a world community is coming together and agree on what the treaty should be. And the treaty should, of course, be all the things we need. But the only thing is, do we all have the same image on what we need? If you look at, for example, I'm not sure if I should go too deep into this, the division of vaccines. There are countries in the world who have more access to vaccines than other ones. From their perspective, and from the perspective of their citizens, you could say, well, they're very happy that we have these vaccines, but at the same time, other countries don't have them. So what do you do? How do you solve that? Those kind of questions come to mind when you talk about a treaty. So maybe you should strengthen production capacities in certain countries, for example. And that is one of the reasons why the Netherlands has volunteered to be the WHO's partner to organize the first global local production forum on medical products, for example. But do all countries envisage that the same solutions are needed to solve this? And that's a political question as well. Because if you produce medicines in all parts of the world, you don't produce them in one place, which economic consequences, for example. And that's what makes global health so complicated. It's easy to say it from the good, the general good of things and how you should treat people and should treat everybody equally, but the world is more complex than that. And how do you find the right solutions for that?
Yeah. So with regard to the local production of medicine, it's also the issue of the patents, and especially with COVID, that the poorer countries say we want to produce our own COVID vaccines, give us the recipe. And the richer country says, well, if you have the recipe, it's not so easy, but we don't want to give the recipe in any case. Yeah, that's a bit the ongoing discussion where the EU states also, some of them have their own vital interests, which are pretty tricky. Let's move on. Coach Michel, the question was posed: should there be a new EU global health strategy now, and what could this be about? How do you view this? Because you just said, well, we don't need perhaps a Dutch global health strategy, though in other countries they have it. In Germany, indeed, they have even this week the Global Health Forum Week. So there's a lot of attention to this issue. But should that be something for the EU level, in your view? To please unmute. Oh, we can't hear you yet.
Even though I spend a lot of time in bureaucracies, I'm not very fond of adding to the bureaucracy with new papers. But anyway, I think there's enough reason now to consider indeed a new global health strategy on the European level. I link in first to what Eleanor said. She expressed her amazement about the fact that so much was done on the European level, which would have been unthinkable a few years ago. And I completely agree. It's amazing on the one hand. On the other hand, it's my experience that the EU doesn't grow linearly. It grows by spasms of progress, and usually after a crisis. So if on any platform the saying is true, never waste a good crisis, it's on the European level. So that could be one reason to say, let's get our act together. But there's more. There's not much use in 28 countries writing their own global health strategies. I say they could define their contribution too, but it would be good if on the European level they could try to coordinate a little bit and set out the focus, and then distribute responsibilities of financial contributions and so on. But it's not only the health sector. Now we have this notion of One Health on the European level. A new health strategy should also encompass this One Health issue. So also trade policies, agricultural policies, animal welfare, and all these kinds of things should be taken into consideration. So if you do it in that way and you put coherence of policies, both on the content level and on the cooperation between the member states, also as a subject in discussion, I would very much agree that a new global health strategy on the European level could serve a lot of purposes. Yes.
Okay, thanks. Loud and clear. Then I think there was one remaining question to you, Roland. So with the pandemic, have the activities of the international part of the Department of the Ministry of Health changed? Have you entered new alliances, new tasks, perhaps? How has it changed the operations of you and your team, which has also a bit expanded, I understood?
I think that the biggest change and for the good of things is not so much that we do different things, but the attention for it and the importance attached to the work. Because we always were in contact with the EU, with other countries, with the world through the Global Health Security Agenda, or the WHO. But the attention for it and then the value added attached to the results and what could be achieved by working together in the world was not always felt as urgent or important. And that has changed. I think that is the biggest change, that people see now that the Netherlands, but not even Europe, is well enough equipped to deal with situations like this on their own. That we need each other, that we're so interconnected and interdependent that we cannot do this solely from the Netherlands perspective, but we need the world. And that's the biggest step forward, I think.
Okay, thanks. I wanted to go back actually to Coach Richel, because you were just pointing out that global health strategy at the EU level, the member states should define what are their contributions to such a strategy. What can they do, and where can everybody play to its strengths? And nowadays it's very fashionable in Brussels to talk about this Team Europe approach, so that we enter the global stage with the Team Europe. So it's not the EU institutions representing us, but it's a mix of, let's say, member states and the EU institutions joining up forces, and whether that be on international politics, security, or the climate negotiations, or development cooperation coordination, it's all referred to as kind of the Team Europe approach. And then it could be very logical that the Netherlands has its experience on this sexual reproductive health and rights agenda, and that it makes a contribution there. But what we also witnessed in our research is that this topic is increasingly sensitive at the European level. And I wanted to ask, do you think that the Dutch will manage to keep this focus on SHR at the European agenda? And also, how do you see the link with the sensitive issue of population politics? Because it seems that in Brussels, if there is an opening to sexual reproductive health and rights, it's more connected in the DG INTPA agenda to the population politics issue, whereas in the Netherlands, that's absolutely not currently the case. Could you say a few words about that issue? Oh, you have to unmute.
Starting with the last aspect, I think the Netherlands, but not only the Netherlands, has been fervently opposed to population politics. Our attention to sexual and reproductive health is mainly related to human rights, and particularly women's rights. That's the start of the interest. And then it developed from there. I don't think that there is a majority among the member states to discuss population policies. That's too sensitive and is seen too much of a private nature and not an issue for states. Although there are a few states that now hand out birth premiums and so on. But it will not be a topic that will fly in Europe, in my opinion, and to my experience. Holding a focus on sexual and reproductive health is a purely political decision. It has to be weighed within all the elements that are there for the budgets for development cooperation, and the prospects for the budget for development cooperation are not very good at the moment. You see that they are generally threatened in this time, and not just in the Netherlands. It's even among the strong supporters of development cooperation, like the United Kingdom, you see a downfall of the budget. So that's a political decision for the next cabinet to be made. The issue as such is a relevant issue, I think. But as I said, it need to be weighed against the other aspects of public health.
Yeah. Okay, thanks. And might also be some questions. But first, I wanted to ask actually a question to Roland Driessen about the joint purchasing of COVID-19 vaccines at the EU level. I wanted to ask, do you think that's in the future also going to become a model for cooperation in buying other medicines? So for instance, the medicines that Maria Jasdan-Baksh is developing, or is the EU going to use, let's say, its market power or for the animal diseases? Do you see a further Europeanization in the field of medical treatment purchases? Let's put it like that. Yeah, please.
Well, I don't know, actually. I think there are good reasons to do that in certain circumstances. And I think if you look at all the HERA proposals, proposals from the European Union on pandemic preparedness and what we should do together, that this is one of the things we should be doing together in the future. But we should not forget that this was a very special situation. We were buying products which did not exist. And that's very different from a normal situation where you know what you need, how many of those medicines you need for your own population, how much you want to spend on them, what kind of medicines you want. We were all under extreme pressure to get in vaccines, get in medical products which did not exist, and to be first in line. And again, I know that is not always popular with people who have a different perspective, but as an EU, we saw what was happening in the US, we saw what was happening in the UK, and we thought if we do not act, we won't be able to get contracts which would deliver vaccines reasonably soon. So we should come together, we should organize our buying power, so to say, as an EU. Otherwise, maybe just France and Germany would have been able to get contracts, and that smaller countries like the Netherlands, but even Malta or Latvia, and the real small ones would be even further down the line. But now we were able to because we bought such big numbers, to be a really serious partner for a lot of those producers of vaccines. And also because they also had a risk, because they were producing something which they didn't know if it would be successful, if they would ever get a market authorization. And some of them, you see now, don't make it till the end. So it was important from their perspective as well to deal with countries or groups of countries who were able to guarantee them a certain return on their investments. So they had the certainty to keep on working on these products. And so in this specific instance, I think it was a very good model and very successful. And again, there's a lot to say if we were quick enough, if we should have started earlier. But I think if you zoom out a little bit and you see what was happening in the short time, these products were developed and procured, that it was, very good work in that sense. But if we need it in general terms for products that already exist, that's something to be seen. But I can imagine that it will be part of HERA for next pandemics in similar situations, but I'm not sure if it will be something for cancer drugs. I don't know. You have to be seen.
Yeah, thanks. And what is your expectations in this respect, Eleanor? Will you see the EU more often join forces to buy and purchase medicine?
Yeah, I think that's a great question, and ties really well to this question of whether the EU will just do more in health more generally. I think the distinction is exactly the one that Roland is making. So, and also this ties into what Koos Rochelle was saying about the EU growing in response to crises, right? So the joint procurement mechanism that we have for medicines right now, we have after the disaster that we had with the last round of pandemic, where we tried to purchase vaccines for the seasonal flu, for the influenza, and that did not go very well, and there were many errors there. We strengthened that system with the cross-border health threats decision in 2013, and now we have the mechanism that we've used now. I would absolutely agree with Roland's characterization that it actually worked very well once it was up and running, but it was slow. There were elements of it that were not quick enough. We've discovered the budget of it is maybe not as much as it could be. The coordination elements of it were not so good, and so now there is a proposal on the table to strengthen again. So I think this absolutely reflects this. We have a crisis. We see how the mechanism that exists has strengths and weaknesses, and we try to address those strengths and weaknesses. The critical question, I think, for how this unprecedented amount of EU action on health will affect us in the longer term is whether those sorts of mechanisms will be extended to areas that do not have to do with crisis preparedness and response. Because at the moment it is all pretty much all focused on exactly that, on making sure that when the next pandemic comes, we don't see a repeat of the mistakes, which is understandable and a logical way to move forward. What I think is much perhaps less likely is that we will see it rolled out into these sensitive areas like cancer drugs. That's a really good example, because that now you're moving into the part of the treaty that explicitly says this is the responsibility of member states. It is not the responsibility of the European Union. So you would need something unprecedented in terms of political will, in addition to potentially some sort of legal change to support that, I think.
Yeah. All right. So these very expensive drugs, the EU market power to use that to lower maybe the prices and to negotiate with the pharmaceutical industry, and whether also countries would be willing to have that, that's still very much an open question, and for the time being maybe rather unlikely. Yeah. All right, thanks. Let's move to Martijn again, because I think the number of questions in the Q&A are popping up rapidly now. Martijn, what else do you have for us?
We have a number of questions about EU and health security. It might be interesting for Eleanor Brooks. One is, to what extent do you see health security expenses rising, and also the focus maybe increasing on health system strengthening within the EU? And coupled to that, do you think that there might be more attention for existing infectious diseases like tuberculosis, HIV, also maybe AMR, for which we are a bit less concerned with the excluding AMR?
So typical Dutch question, is this all going to be much more expensive? What else do you have, Martijn?
There is a question on which is related to EDCTP actually. What might the role be in the future Dutch health strategy for developing vaccines and other technologies for diseases that currently have no vaccine? So it's a bit related to the previous question. Might the Dutch also prioritize that and in our development policy specifically? Yeah,
so I think that would also be a question for Professor Jos den Banks. So she is doing research in these neglected diseases, as they're often called. So the diseases that we don't have so much in the Netherlands, but that prevail very much in countries which have less means to put R&D into them. Should that be more of a priority? And can you even say there is also an interest for us if we invest in that? How could we view this question politically? But maybe also others want to answer it. Do you have one more question? And Inge, could you bring back Professor Jos den Banks to take part in the discussion? Yeah, please.
I have one overarching question, maybe for Koos Richel, which you already touched upon, that often the development or health development agenda is often politically driven. Ministries, of course, have to be accountable to their parliaments. On the other hand, the needs of the developing countries are not always considered when developing these countries in developed countries. So would you say that how would you say that we could maybe fix this clash between politically motivated contributions to development aid and the needs on the ground and the local ownership of developing countries?
So yeah, global health needs to be needs-based. What are the needs of these developing countries? How can we find out, and how can we best respond to that? And how does that link up to our desire, or the taxpayers and parliament's desire, that all the money that is spent is also output related. As Kosi mentioned in development cooperation, there was this huge shift to funding being results oriented, output related. But how is that squaring with the needs-based assessment? Let's first start with the health security expenses. Eleanor, please.
Yeah, I think that's a really important question, and I mean the sort of initial answer is to say, well, it's all over the documentation, right? The EU for Health programme, there are huge subsections of it that are about health system strengthening. The European Health Union, lots of the documentation that supports that contains language on health system strengthening. I think it's going to come down to a more nuanced sort of assessment of how much that goes beyond preparedness response. So for example, the EU for Health programme work programme for this year has quite an extensive set of actions on health workforce. Now, that's an area that the EU has worked in for a long time, but it's mostly in a supporting capacity. It doesn't do too much more than support or coordinate national actions in that area. So it will come down to, as this thing, the EU for Health programme and also the other elements of what the EU is doing roll into action, and the actual programs and funding and projects and things begin, how much of them end up being about more than the next pandemic, as it were, I think is the answer to that question. Linked to that, I guess, is the point about prevention and NCDs and all of these things that the EU again has only ever performed a supporting role in.
The NCDs.
Sorry, non-communicable diseases. Forgive me. So the non-infectious diseases, the cancer is a good example, but also various other things that are much more linked to healthy environments, and this debate between lifestyle and environment, and whether it's individual behaviours or structural factors. These are areas where the European Union has traditionally supported national action, but certainly the public health community would criticise that has not done enough, much as national governments don't do. We hear about a 3% budget for prevention and 97% for treatment and cure, right? That balance is clearly not ideal. So a lot of this comes down to whether the EU is able to shift and put more emphasis, to take the momentum that we have out of COVID and put more emphasis on a prevention rather than a cure sort of perspective. Just to quickly touch on the question about infectious diseases, I actually think the critical thing here will be the data. So because so much of what's coming out now is focused on improving the data infrastructure and the information that the ECDC is regularly able to get from member states, and the surveillance infrastructure linked also to being able to map the capacities of member states. So one of the key problems at the beginning of the pandemic was that we simply didn't know at European level which member states had which capacities, and from a public health perspective, because the structures, the agencies, the ministries involved, the various officials, the way in which things are divided up and organised at national level varies so much, and there was not a comprehensive sense at European level of which countries were going to struggle, if you like, even, and which would be better equipped. It just wasn't known. So this data infrastructure and information infrastructure might end up being the most important part of that, and enable us then to also feed into a more comprehensive treatment of existing infectious diseases as well.
Right, yeah. So in order to curb the outbreaks and to address them, you also need these health infrastructures to do it. And we didn't have the good oversight. Exactly. Yeah, we were also shocked here in the Netherlands with the amount of, or the little amount of ICU units that we had, apparently, because our health system had become so lean and mean, and cheap for that matter. In comparison, we were very proud of that, but then, with the pandemic, we learned also the negative side, and now we struggle a lot with the workforce, like you in the UK, with the workforce that's not available to serve in hospitals. Yeah, let's move on. Maria Jasdabank, the question about the neglected diseases. So could we see perhaps a stepped up effort of the EU in that regard? We've also seen quite a bit of talk on the issue in the WHO in the past years, but is there really now action and budgets being freed up, do you expect? And what could you also argue that there is something in it for us, beyond the charity objective?
Yeah, thank you. I think, the complexity of the global health was very nicely argued by Ronald Drissa. I really like that. But I think a few things that came up also, it's very much an EU thing, I understand that. But of course, pandemics don't just stop at the EU borders. Things like malaria, HIV, TB, of course, are much more a problem in the global south. But if you make vaccines for these diseases, they're going to help us as well, travelers, but also the army, for example. I mean, we do have armies stationed all over the world, so they will be using those vaccines. If we need to really think about what is the benefit for the taxpayers. But the other thing is, I thought was interesting, the whole time saying, you know, there's a lot of mistrust. When you want to get something together to implement certain policies or agreements on international health, people don't trust each other. Well, one of the ways to get the trust, I think, of many countries and governments in the global south by showing that we are concerned about the malaria situation there and we're willing to produce vaccines. And then again, show leadership. I was so pleased to hear about the leadership of the Netherlands in terms of making facilities in maybe global south to actually produce vaccines or drugs. That's a great leadership we're showing, and maybe we can show that leadership also in other areas. Netherlands, how we can work together with the global south to get the trust, but also, you know, equality. I have a question. Could somebody answer? Can we also learn something? It's the whole time we're going to help. Can somebody answer the question? Don't you think we can learn a lot from the global south as well if we go beyond Europe, US, etc.? Personally, I've learned a lot, but I'd like, not personally, in terms of my research, I'd really like to know what people think. There's a lot we can learn.
Yeah. Simply go out there and ask them how they do it.
For example,
how did you manage previous
partnerships? Yeah, no, not only the pandemics, but partnerships. And yes, we should produce vaccines if we can. If we have a good vaccine production facilities, or the science behind it, we can very quickly switch from whatever is important for us also to whatever is important maybe in Africa, malaria, for example, among others.
Yeah.
I hope that answers your question.
Yeah, I think you've also said somewhere that perhaps indeed malaria vaccines at this stage are more important than COVID vaccines for instance, for Africa.
I think, that's TB, HIV, you name it. There are many diseases, meningitis.
Yeah, exactly. Yeah, and also, well, Remco's not here because he's in Berlin in the Global Health Forum. But Remco van der Pas, our colleague, he told me that he was teaching with people from Africa, and also that they didn't even want our vaccines because they didn't really fully trust the Western vaccines. They preferred, some others from other parts.
Why does this trust come? This trust comes from inequality, as we know, even within the Netherlands. So I think we need something new, and it'll be so great to see a leadership on that level of new ways of approaching global health with all the challenges that were mentioned by very experienced people like Aldris and them.
No, so it's that for me at least, I was told this about half a year ago, and it was also a bit an eye-opener. Oh, they don't even want our vaccines.
Distrust.
It's pretty bad. That maybe brings me to the question on the needs-based approach to development cooperation versus the desire for funding, and also the desire for Parliament and taxpayers to know how this money is spent, preferably with quantitative indicators and amounts. Koos, how do you view this issue? How can we square this circle, perhaps? Please.
Well, that's very difficult because it involves a lot of rational and emotional aspects, I must say. Development cooperation started in 1949 as an act of solidarity under the United Nations, but it derailed into charity for a long time. And according in the line with charity, that implies something as inequality. And I know better, I'm in a better position, so I will help you, but under my conditions. And that atmosphere that is up and down in development cooperation. You see that also in the fashions of development cooperation. First, it was the idea of technical assistance, of budget support. We give them money and then they can do with it what they want. after a while we said, well, that's not ideal, let's do technical assistance. But it was not assistance, it was white consultants going down and taking over, in fact. And as the late Prince Klaus always said, you cannot develop a country from the outside world, the country has to develop itself. And you have to support it in that way. Now, you have seen periods in time over the last 70, 80 years in which in development cooperation, they tended to go in that direction. For instance, by providing budget support and saying, okay, you can make your own choices, but build in your own institutions and your own policies. And that then comes down again into following each euro into a brick of a school where only girls get their education. If you go in that way, you are temporarily interested in a school and the education that's there. But if you need to follow another fashion and you leave the school alone, there's no system, there's no institution, there's no way the local government, national government can take over. You see gradually that in some areas there is, to a limited extent, learning from the developing countries. Community care, for instance, is one of the areas where you see that happening. Also, the over-attention in the Western world on technologies, which it's not possible to implement in developing countries, and the way in which they get around it, where nurses get responsibilities through distance learning in doing much more complicated things than nurses do in our countries. The transport of medication through drones and this kind of thing, the use of digital facilities in such a way that they support the local organization in a village and not expect people to travel 50 miles to get what they need to get. But it's very limited. We have to be honest. Most of the time, money from development cooperation comes with strings attached. And you can say the only one that doesn't do that is China. But China brings other strings in, mainly debts and financial strings, which is also not the best way to help countries out. But we need to go back to solidarity, and it's not just because of the good heart. Solidarity is also a matter of considered own interest. It's our interest also that those countries and those peoples develop. And we should never forget that. And not only limit that to when there's an actual threat of a communicable disease, but simply in a way of cohabitation on this earth.
Yeah. All right. I think we have to round off. But perhaps I can ask all of you, maybe if there is one main takeaway from this webinar that you want to bring home, and maybe I can also ask it to Martijn, who's helped us and is also helping us with writing the policy paper for this field, and he has actually also worked himself in the hospital at the beginning of the COVID outbreak as a working student. So maybe each of you can be asked your main takeaway, and then we'll close off for today. And of course, we wanted to address more of the questions, but as always, we had to take into consideration the time that we take from the audience and from the speakers. Please, Leonor, what's your main takeaway from this discussions that we had today?
Yeah, thank you. And thank you for a super discussion. I thought that was some of the points that have been raised are really fascinating. I mean, I guess just to pick up on Chris Rochel's last point makes me optimistic. I think when we study the history of EU health policy from a political science perspective, it has developed functionally. When there is a functional self-interested reason for something to be done and coordinated at European level, that's when it has been done and coordinated at European level. And if what we're being demonstrated now is the functional reasons for working together on more things and more often, and also then reaching out beyond the EU's borders to ensure that the EU is involved and influencing in the right ways outside of the EU as well, then I am optimistic that things will move forward and we will see pretty important developments over the next couple of years.
All right, thanks, Eleanor. Roland, would you like to add your observations?
Yes, thank you. I think what this little debate showed is that how many sides there are to this global health issue and the global health problems we see, and that there are no easy fixes or easy solutions, because it's a very complex of issues. And at the same time, there's only one world and there's only one world population, and we have to deal with it together. And I think what's happening on the world, be it climate, environment, health, it shows that we become interdependent more and more. And so there is no other solutions than working together as good as we can. And many times we will not succeed, but then we try again.
All right, thanks. Maria, what's your main takeaway?
Well, I thought it was really very interesting, and it'll be good to have more of these discussions to grow together towards a new way of dealing with global health and to dare and show leadership. And I think part of that is, honestly, I'll come back to this EDCTP. It was a fantastic way of doing it. It's an important part of it. So I hope we can really convince people to support such thing and new ways of dealing with global health. Yeah.
Yeah. All right, thanks. Koos, what is your main takeaway from this?
Well, I'm almost inclined, being 7 years on retirement, to go back in active service. It's such an interesting and demanding time, I think, and there's a lot to be done. So let's hope that it will be done, that we come to some conclusions, because it's enormous and it has long-term effects in what we do or don't do at the moment. So a sense of urgency, I came already in with it, but it is deepened and broadened at the moment. That's what I take away.
All right, thanks. And Martijn, what is your main takeaway?
I think the main takeaway is that besides all the bad things that we've seen in COVID, we've also seen a huge reappreciation. It's a reappreciation for global health and the institutions that work in it, whether it's the WHO or the member states pulling together and purchasing vaccines together, for example, but also reappreciation of things like the EDCTP and what we might learn from each other and from partners which we otherwise maybe don't look at as teachers. But I hope that in the future we continue this appreciation, also continue this dialogue and cooperation, for example, in the EDCTP.
All right, thanks. Well, I also learned a great deal, and for me, it's always the most important that it's so worthy to listen to people, just to hear what they say, think about what they have to say. And I think in the end of the day, that's true indeed globally. Go out more often, find out what others doing, why are they doing it, and how they are doing it, and try to see if you can learn from that from a perspective of international solidarity. So I greatly appreciated this. Thank you again for your willingness to participate. Thank you again for your willingness to speak in this webinar. Much appreciated, and we hope to see you back in future Klingendaal events and on the Klingendaal YouTube channel. Thank you.